Hello everyone, my name is Sandra Rogue. I'm a Senior Trainer in Workforce Development at Turning Point. Welcome to today's webinar. This is the first of a series of 10 Connect and Learn webinars designed to support the alcohol and drug clinicians throughout regional and metropolitan Victoria. They're hosted by Turning Point and they're funded by the Department of Health and Human Services. These webinars will be presented by a range of experienced clinicians and researchers currently working in the AOD sector in Victoria. Before I introduce today's presenters, I would like to acknowledge the traditional owners of this land upon which the presenters and the participants are located and pay our respects to the elders and the elders of other Aboriginal communities. We are delighted to be launching the series with two of Turning Point's clinical specialist staff, Dr. Kathryn Hawkes and Dr. James Gooden. Kathryn is a senior clinical neuropsychologist with extensive experience in paediatric and adult neuropsychology fields, including adult and paediatric neurorehabilitation and neurology, paediatric oncology and aged care. And James is a clinical neuropsychologist based at Turning Point 2, at our new location in Richmond, which provides specialised neuropsychological assessment and associated recommendations and strategies to clients from the AOD sector. Both James and Kathryn are based at Turning Point's new location in Richmond. But before we get started, just a reminder that the webinar will run for around about 45 minutes with an opportunity for you to ask questions around midpoint. So if you'd like to ask questions, there's a chat box on your left, and then you can ask questions again at the latter end of the webinar. You'll also get an opportunity to respond to an online poll that we will tell you a little bit more about later on. This presentation will be available in the document folder found to the right, I think it's the right, of your screen, and we look forward to any questions or comments. If you're having any technical problems, just go again back to the message section for support, and you'll see the number there. So now I'd like to hand over to James to start the presentation.
Thank you very much. So the start off, we'll talk briefly a bit about our role in neuropsychology in the AOD sector and what our sort of role involves, and I'll touch on briefly a bit about the assessments involved for cognitive impairment and acquired brain injury and the types of things that we look for and think about as part of these assessments. The third aim for this talk as well is to cover the strategies to support your client. So these are kind of the common recommendations that we find ourselves often making, and also how to make a referral to our service if this is something you feel your client might benefit from. So first up, a bit about who we are and what our field is all about. So we're psychologists with master's or doctoral level training in neuropsychology, which is essentially the practice of looking at brain dysfunction. So we're particularly interested in the impact of brain injury on an individual's behaviour, emotion, thinking and memory skills, so cognition, and everyday functioning. And our goal is really to provide a bit of an interpretation of the difficulties that a person might be experiencing in the context of their history, so their medical background, their psychological background, and their sort of everyday difficulties, and try to explain and interpret this information to give referrers and other clinicians working with the clients an idea of why a person might be presenting the way they are, and sort of help account for some of the difficulties they're facing. And the overall goal for this is to really help with individualized treatment planning, to provide really tailored recommendations and strategies for the client. So obviously if we know what their weaknesses and strengths are, then we can play to those accordingly. But on the other side of the coin is if we don't know what their weaknesses are, we're sort of flying blind, we might be making inappropriate recommendations or asking too much of our clients. So really we like to aim to provide this level of information to support our clients. So the kinds of clients that we see in neuropsychology overall is really quite varied. So these include seeing clients with neurodegenerative conditions, so things like Alzheimer's and other forms of dementia, and as well as a number of neuropsychologists work in the developmental field, looking at things like intellectual disability, attention deficit hyperactivity, and a lot of clinicians in this field tend to work in pediatrics and explore those developmental conditions in that context. Another big field is looking at acquired brain injury, and in particular things like traumatic brain injury, where an individual has sustained sort of an injury over their lifespan and is then presenting for help as part of, say, a rehabilitation service. So you often find a lot of neuropsychologists in that rehabilitation field. As well, we also work within the context of mental health and psychiatry, and exploring the cognitive deficits that might be occurring as a result of psychosis, schizophrenia, or other mood disorders, and looking to support clients in that context. And in our field in particular, we're looking at substance use. Sorry about that. So we're looking at, in particular, drug and alcohol substance use, and the effects of that on the brain long term. And a bit of a timer issue here. That's all right. And one thing unique to our field is that we find we're dealing a lot with multiple different conditions and aspects of the history for the clients. So many of them have dual diagnoses, so psychiatric or mental health issues, as well as maybe a brain injury, and some as well as developmental disorders as well. So in our space, we tend to work with a very mixed bag of clients with very sort of at times complex histories. So a little bit about what we do, and this is often a interesting discussion to have with friends, other colleagues, and patients. Often our clients attend the initial assessment thinking that they're going to undergo some sort of scan or have all sorts of leads attached to them. And then we have to sort of explain that, well, it's going to be more of an interview and some paper and pencil testing. Similarly, a lot of our friends think that we're psychoanalyzing them all the time, of course, which I have no skills whatsoever in. So really what we're doing with clients on an everyday basis is providing probably a 3 to 4 hour long assessment where we're spending the first hour gathering a full clinical history in as much detail as we can, with a particular focus on their medical history and key concerns that might have picked up on as part of their thinking and memory skills, and any changes that they've noticed over the years. Then we spend the remainder of the time doing some paper and pencil tests that will look at aspects of those thinking and memory skills. So a little bit like what I'm supposed to do picture here is it's sort of a bit more hands-on at times. And within that we can provide a bit of a diagnostic opinion, but as well that sometimes that's not necessarily appropriate given the histories of the client. So where we can, we provide a diagnostic opinion, but that's not always the case. And what we do spend a lot of time as well, and in addition to the assessment, is gathering as much external information as we can. So that means going to requesting information from previous hospital visits, previous assessments, and other services that the clients have been to really get a full picture of that client's history. And particularly in our field, that information is incredibly valuable, as our clients often don't really know the full details of what happened to them at certain circumstances or what happened during a particular admission. to hospital, and all of that information might be a bit vague for them. So as much information as we can get is always very helpful for us. So touching a little bit on what cognitive impairment is and some of the, causes of it. So essentially, cognitive impairment is damage or disruption to neural networks or networks within the brain, and damage to structures causing a variety of impairments. And this can be as a result of sort of permanent or persistent causes, so things like acquired brain injury or traumatic brain injury, or a disease process like a neurodegenerative condition, or a developmental delay or condition on that front. And with these causes, we're generally expecting to see a fairly permanent and at times very significant impact on their thinking and memory skills and everyday functioning. In addition to this, though, we do have to always be mindful of the variety of variable causes to cognitive impairment. And this can include things like a person's mental health, where the severity of their difficulties might fluctuate in accordance with the severity of their condition. And similarly, substance use is a really big a variable factor as well, where persistent or ongoing use might lead to exacerbations in their impairment, as well as withdrawal will change that, and then recovery as well after a period of abstinence. And as well, we also have to consider some of the everyday factors like a person's sleep quality, their general sort of lifestyle, levels of stress, as all of these things can really significantly impact a person's ability to function and perform on assessment in our sessions. So at times, we do have to send clients away because they're just clearly not in a fit state to be assessed, and we'd rather catch them when they're a bit more rested and in a bit of a better state of mind, to really try and look at to better unpack those more persistent causes and evaluate those formally. So a little bit about acquired brain injury and so the types of things we look for on that front. So acquired brain injury is essentially damage to the brain that occurs after birth. And the sort of two main branches of this are traumatic brain injury and a non-traumatic brain injury. A traumatic brain injury is essentially when a brain has been subjected to an external force. And the common examples of this are a motor vehicle accident, a fall, or assault, for instance. And so, for assault, the one-punch attacks, for instance, where a person has been knocked unconscious and they've fallen and their head struck the concrete, for instance, yielding a significant amount of force on the brain. Within this, though, it is important to note that not all head trauma results in a traumatic brain injury. And it really does require a lot of force for the brain to result in sustained permanent damage or changes. So we do tend to get referrals at times where a person's been referred because they've had a number of hits to the head or a couple of concussions, and then we're starting to look at, well, how long were they unconscious for? Did they have to go to hospital? And how significant were the changes that they noticed after that event. And that sort of helps us unpack how severe that injury was. And in many cases, if they haven't had a significant sort of hospital visit or noticed any really significant changes, we're generally not too concerned on that front. In terms of non-traumatic injuries, this includes things like chronic alcohol and substance use, or hypoxic events such as in overdoses or a cardiovascular or heart attack, and essentially where the brain's been deprived of oxygen for a period of time, and that started to impact the structures and networks within the brain. And this also includes things like tumours and strokes and other neurological disorders. So why is this really important? Well, it's particularly notable because traumatic brain injury is more common in younger adults, males and those from lower socioeconomic backgrounds. And as a result, this can really significantly impact their everyday functioning and the trajectory of their lives. And in particular, many individuals have their whole lives ahead of them and may not necessarily have access to the same level of services and resources that others may have, which could impact the quality of their rehabilitation and support post-injury. It's also particularly an issue in the criminal justice setting, as a lot of research has shown that the prevalence of acquired brain injury is up to 30 to 40% in forensic populations, which is very dramatic when you look at the comparison to the general population. So in certain circumstances, it is something that we really have to be very mindful of and assess accordingly. And the impact of cognitive impairment is very significant, and there can be a wide range of impairments that will impact their everyday functioning. So, for example, some of the domains that we look at are things like attention, memory, speed of thinking, a person's organisational abilities and planning. And what we might find is that a person might go from being initially very quick and very quick to process information, and post-injury they're suddenly very slow, and they're struggling to keep up, and they're becoming very overwhelmed, and that might lead them to misinformation and struggle with everyday life. Similarly, if they were initially very attentive and organised, they might post-injury be very distractible, or find it very hard to concentrate, or become very sort of disorganised as well. And the important thing, I guess, with cognitive impairment is that the domains all sort of relate to one another. So if a person's got good attention skills, that will support their memory. But conversely, if they've got impairments on that front, then it might lead them to have more difficulty in processing memories and recalling information accurately. So a lot of the time we might get referrals for a person having memory problems, but those problems might be better accounted for by difficulties in attention or concentration or organisation, for instance. So that sort of gives you a bit of an idea of the kinds of impairments that we might see. And what we know with substance use and alcohol is that long-term and sustained use can really impact a person's cognitive functioning. And this is really dependent on a number of factors, and these are all the factors that we have to weigh up and consider as part of assessments. So this includes things like the amount that they've used, the intensity and the frequency that they've used, and how long this has occurred for. And it really does take a long time and a sustained period of heavy use to start to see more permanent difficulties. The other factor that we really look at as well is how early on in their lifetime they started using. And this is based on the fact that we know the brain's still developing up to the early 20s. So if a person is using heavily in their adolescence, then that could disrupt those normal developmental processes, leading to difficulties down the track. As well, we're also mindful of the complications from substance use, so things like maybe infections or overdoses and things like that. That also could create a bit of an additive or compounding effect on their functioning. So the golden question in our field is, well, what substances impact what skills? And unfortunately, the answer is a bit vague, and the impact's very sort of diffuse across a range of skills. And the research in this field is also very tricky because a lot of the the research is focused on maybe one substance, whereas what we know in clinical practice is a lot of people use a variety of substances and sort of vary the amount that they use. So getting a clear picture of what has certain effects is tricky. The main message in what we see in the clinic and every day, sort of working with these clients, is that there are a range of impacts and skills that are impacted by long-term substance use. And it's not really limited to one skill in accordance with one substance. And as well from the research, we know that there is a generally good scope for recovery. So we really strongly advocate for abstinence and supporting a client towards that to really help the brain recover. And it does take quite a long time for the brain to do so. So it can take months through to years for the brain to start recovering after a substantial period of substance use. So, in summary from my section, the impact of substance use in our role is really complex, and our clients are very variable in what comes to the door, and there's often a range of different factors and things that we have to consider, and things like trauma histories and unstable environments and mental health difficulties, as well as medical problems, traumatic or other acquired brain injuries, as well as ongoing or variable substance use. So within our role, we really try to weigh up all of those factors and consider them as part of our assessment to try pick apart what might be going on for the client and support them as well. So at this point, do we have any questions?
There is a question just regarding whether the slides will be available following the seminar, and they will be. They're available in the folder box at the right-hand side base of your screen. So anybody looking for them, they've been made available. Thank you, James. That was a really comprehensive overview of your role and what you're looking for people who are using substances and who might have neurological problems. I guess potentially there's going to be a range of questions at the end, but just one quick one from me was, what kind of time frame does it take to work with somebody who is referred to you?
So we have a lengthy wait list at the moment. So our wait list is at times anywhere between 3 to 4 months for an assessment. Once a referral is being made, we'll contact the referrer when we're able to make an appointment, and we'll then talk through and get an update on how things have been going for them. Once they're booked in, we generally try turn around a report and go through feedback and those processes within about 2, 3, sometimes 4 weeks, depending on how much information we're able to gather and what sort of time frame for the client. But generally, we expect to spend about 5 hours in total with the client. So about 4 hours for an assessment, and then an hour feedback session a bit later on as well.
Great, thank you, Sandra. So I'm going to continue with our presentation, just talking a little bit about how people might be able to help their clients who do have brain injuries. And these may be some things that you're able to do while you're waiting for the assessment, or even to implement after they've had an assessment and you've gotten the report back. So in terms of strategies to compensate for difficulties in thinking or cognitive deficits, we actually all have cognitive deficits. From time to time I forget a lot of things, and we all have to remember different things. So this chap here, you can see he's remembering lots of different things. He's got to remember his medication, he has to remember what to cook for dinner, he's got to remember things for work. And I'm not also sure why exactly he needs to remember a gun. I think maybe that's his hobby there. He also needs to figure out what clothes to wear, what weather's right. And so when we're trying to develop strategies for our clients, it's really important that we tailor them to the individual. They need to be relevant to their life, relevant to their individual, and they need to play to the person's strengths. So are there any strengths that they previously had where the client can use those to compensate for weaknesses? So somebody may still, for example, have good reading skills. They can write things down and they can read them. Other people may have good attention. So there's different things where, we can help the client there. The other thing that you can do is build on previous strategy use. So if you know that somebody used a diary before, then this can be helpful to them now. But if they never used a diary before, then it can be really difficult to teach them, how to use a diary now. Or just say they were very technical and they like their smartphone, then that can be a really good way to go into strategy use. So from a memory point of view, these strategies that I'm going to talk about now are more specific to memory. So when we were all studying, when we were at school, you must remember that we would spend a lot of time revising our work. We'd write it down. We might have had flashcards. We might have written things and put them up in places where we could remember. And basically it works like this. The more that you try to remember something and the more times you use the information in your memory, the more likely you are to remember it. So this is helpful for our clients where we can get them to remember and rehearse the information we want them to learn. The second thing is that recognition is much more easy than recall. So I'm sure you all know that scenario where you have taken a photo of something and maybe you're looking over old photo albums and you see some photos from a holiday maybe many years ago, and if I remember that holiday, I'd forgotten so-and-so was there, or I remember this now. So recognition is much easier than recall. And for our clients, we can prompt them. So we can say, you had an appointment last week. Do you remember that? Oh, and they say, I don't remember. Then you can say, it was at the doctor. Do you remember going to the doctor? And then they may well remember that. The other thing to remember is that forgetting is actually adaptive. So if we try to remember everything, it's not going to work. Our brains will be very cluttered. So having some information that we forget is actually useful to us. So if you do forget things, certainly don't feel worried about it. It's quite normal to forget some things. So these are some examples of memory strategies that we can use, and I've mentioned a couple of these here. Although we can work on remembering information in our heads, which is called an internal memory strategy, and these can be things like, where you're trying to remember, say I'm trying to remember James's name, and I say, his name is James, and then I try to think of someone famous whose name is also James, and then I try to remember something else about James to remember him. So that's an internal memory strategy, and they tend to be very effortful and take a lot of effort. So our clients and most people actually don't use these kind of strategies. The external memory strategies are much better and easier to use. So these can be things like using your alarm on your phone, having a calendar, having pin boards, having visual reminders. We recently got gifted a Google Home, and so now I can ask her to set alarms, and that way I don't forget certain things. Very helpful. So technology can be a great help, and we'll chat a bit more about that as we go through this section of the talk. These kind of visual reminders are also very helpful in organisation. So a lot of our clients have difficulty with organisation, and they struggle to remember where they've put things, they misplace things, they have trouble with routine. So having lots of external reminders is helpful, and it reduces the load that you have to keep on working memory. So working memory is where you rehearse things, and this is when you're trying to remember something. So I could set my alarm in Google Home, and then I can simply forget that I've got to do something at 9 o'clock. Or if I don't, then I have to keep rehearsing it, and I have to keep thinking, what do I do? What do I do? How do I remember that? I know I have to remember something at 9 o'clock. How do I make that happen? So it's very helpful to reduce that cognitive load. So this is an example of something that we talk to our clients about. This is what we call our memory station. So it might be somewhere in your house where you have absolutely everything that you need. You can have a whiteboard, you can write your shopping list on your whiteboard, you can put bills on your whiteboard. If you need to remember medication, then you can put that in front of the whiteboard. It can be that place where everything gets put. And again, for some of our clients, this can be incredibly helpful because they don't have a structure or an organisational way of managing their things, and then everything within their lives is very chaotic. But if we can help them to have everything in one place, then that can really help to get around some of those cognitive problems that they have. So Google Calendar as well is something where there's actually been research done around how it can help people with acquired brain injuries. So you can set reminders with prompts, you can have lists, you can use it for goals, you can actually have it sync between different calendars, you can have a daily agenda, and the research finds that it does work pretty well for clients with acquired brain injury as long as the person manages to use it and their worker works with them to make sure that they can use their Google Calendar. If you had a client who wasn't technically savvy, then I think you probably wouldn't want to go down this route. But if the client does like gadgets, then it's probably a good way to go. Yep. So some of the other compensatory strategies are what we refer to as environmental modification. So these can be things like James already mentioned that clients often slow down. So if we speak too fast, then they also can't keep up. So you can slow down the pace at which you present information to them. Some of our clients are very easily distracted. So when they come into their session, you might get them to turn their mobile phone off. You might also go somewhere quiet. And the other thing that you can do is break things down into much more achievable steps rather than presenting everything at once, present things in smaller amounts. You can use simple language, and keeping a good routine can't be underestimated. So for a lot of our clients, they have difficulties with planning and organisation, and being able to have a routine means that you don't have to think about what plans you have that day. So one good example of this is that Barack Obama, I heard it said, simply wore the same suit and tie every single day, so that was one less decision he had to make. He could save all of his brain space for running America. So these are some of the ways that we can have routines in our daily lives and get around cognitive deficits. Here's an example of a routine. So a lot of our clients, we notice, just don't have a good routine at all. They struggle to know when to get up. They don't eat regular meals, which is a huge problem for clients with alcohol problems. They may forget to take their medication. Some clients struggle to keep routines around daily hygiene. Certainly don't exercise. Some struggle with housework and also keeping appointments. So having a daily routine that's very strict again means that clients are able to get around some of those executive difficulties they have. If you're going to develop this kind of routine with your clients, then you would want to work with them so it's a routine that they like. Again, you don't want to impose upon somebody something that they've never done, just because you think it might be helpful for them. We all have the best of intentions when working with our clients, but it does really need to fit with their goals and what they want. But sometimes developing a routine can be really helpful. Mental health is a very important thing to look at. So James mentioned this at the beginning of the talk, where you want to look for any potentially reversible causes of cognitive impairment. So mental health is one such thing, and we know that if people are depressed or if people are anxious, then they can end up, feeling really not great. And one analogy we can use with our clients is that our concentration skills are like a bucket, And if our bucket is full of worries or sad thoughts or negative evaluations about what others may be thinking, then we don't have any room in there in order to be able to cope with the other things that we want to remember and do. Post-traumatic stress disorder is another one that really affects how well your brain works, as does depression. So for these sort of things, you really want to try to address the client's mental health problems, which will in turn alleviate some of their cognitive deficits. One of the things that you can do is book a long consultation with the general practitioner to obtain a mental health plan. You can send your client for a psychiatry review. This can be called a 291 in the Medicare numbering sort of system. And you also would want to check that they're compliant with the medication that they're being prescribed. Not all of our clients take their medication appropriately, so making sure that they're doing that is one way to do it. You can also look for psychologists on the APS Find a Psychologist website. So in terms of making a referral to Turning Point, these are some of the ways that you can make sure that you get the most out of an assessment. The kinds of questions that we answer are, does the client have an acquired brain injury, or what is their diagnosis? We can help to characterise their current functioning and how best to work with them. Or maybe you think your client has declined and they've actually changed from an assessment they previously had. And so we can do a review assessment and maybe let you know if it's related to their ongoing substance abuse or something else. If we want to answer a diagnostic question, but the client is currently still using substances, then that's quite hard for us to answer. So it's better if the client is abstinent at that point in time. And sometimes the client will benefit from detox and mental health treatment before they see us. You also want to consider whether the client is actually ready to implement our suggestions, and will our assessment be helpful at this particular point in time. So these are our referral criteria. They need to be adults who have an alcohol and drug history, and they need to be engaged in an ongoing support service. So in order for any recommendations that we make to be effective, there needs to be someone else to help follow them up with the client. Our clients need to be able to come to our clinic in Richmond, and they need to agree to the referring agency receiving a copy of our report, again, so those recommendations can be implemented. The referrals that we don't take are any kind of capacity referral that relates to either parenting capacity, capacity to testify, or to make decisions. And this is because these sort of assessments are better done within a team context, and they're often related to a certain point in time. And so what we know is that, as it's much better if these kind of assessments are done with a treating team or a specialist at that particular point in time. We have a long waiting list, as James mentioned, and so our assessments can't be at the time when you probably need them to be. We also don't do medico-legal referrals that relate to sentencing, and we aren't able to do assessments where one of the questions might be around autism spectrum disorder. So this is how you can find our referral forms. What you do is Google Turning Point Neuropsychology, and there will be a form there on the website. You fill that out and you can send that to us. You can either email it in or you can fax it. There's also certain procedures for ASCO coats to refer to us through their brokerage service, and then we'll contact the CCO and then organise the assessment from there. As much information as you as the referrer can give is really important. That helps us to get some ideas about the kinds of problems that the client has in daily life. So your opinion as the referrer and the person who knows them well is really important. It could be that the person's impulsive, or they're deteriorating, or you notice that they just can't seem to get to appointments even though they appear to have the best of intentions. And these are really good referral questions for us. We do two kinds of services. We do either a detailed face-to-face cognitive assessment that James described, or we can do a secondary consultation, which is where we spend time talking to you about your client and what sorts of difficulties they may be having and how you might be able to support them. And this advice is provided by the phone. So this is what happens. Once you've made a referral, we email you to let you know we got it. At the moment, we have around a 4 to 6 month wait, but this does vary. If a secondary consultation would be helpful, then do let us know, and then you can try implementing some of the strategies that we've suggested today. And then when the client is near the top of the list, we'll call you and let you know that we're about to ring them and make an appointment. When your client is ready to come for their assessment, please do help prepare them. Let them know that the assessment is lots of sort of pen and paper tasks. It's a bit like school, but there's no pass and there's no fail. And most people actually quite enjoy it. So it's not, although it's 4 hours, it's not like 4 hours of sitting an exam. It's usually quite fun. If people aren't abstinent or they're still using at the time of the assessment, that's fine. You know, we can still see them and talk about their strengths and weaknesses. But it is helpful if they're not intoxicated when we see them. So we do tell people, you know, take your usual medication, but, you know, if you can, please don't drink on the morning of the assessment, or please don't, you know, use drugs on your way in, because then sometimes we have to send people away. It's also good if they get a good sleep rather than, you know, come very tired, and if they eat breakfast. And of course, glasses or hearing aids if they happen to wear them. So just, I guess, the take-home points from us are that using alcohol and drugs can definitely impact the brain. Neuropsych assessment is helpful for understanding thinking skills in the context of alcohol and drug use. We are a free service. There is, you know, no cost to the client. The more information you can give on the referral form, the better for us. And we need you to support your clients to attend the appointment. Because of our waiting list, if they don't come, then it's unlikely that we'll be able to book them in again soon. They'll probably return to the bottom of the waiting list. Okay, so I think that's all from me. Last thing, we are having a poll. So we're planning a follow-up neuropsych webinar, and what we're really keen to know from you is what substances you might be keen to know more about. So we would adopt a case-based approach for this, and the substances that we would like you to indicate, here's the poll now. You can indicate 2, so whether you would like to know more about alcohol, cannabis, methamphetamines, opioids, or benzodiazepines. So select 2, and then the next webinar we do, we will endeavour to answer some of your questions.
Thank you very much, Kathryn. That was wonderful. I'm just going to start wearing the same clothes to work every day, I think, from now on. As you can see, the poll is showing all sorts of interesting responses, and methamphetamines is certainly showing a real indication of interest, as is alcohol and benzodiazepines. But we'll certainly respond to your responses and within the next webinar that Kathryn and James are involved in. Just a question to you, James, just regarding what sort of advice would we give our clients about how long it takes to recover from the cognitive deficits? Do we give that kind of information out, or is it wise not to say anything?
Yeah, so I do. I guess my first line is always to say never with the brain. That, you know, it's often at times tricky to comment on how much recovery to expect and how long this will occur. but we generally would expect a few months as sort of a minimum, and I think some of the research has shown that it can take up to a couple of years for the brain to start recovering properly from a long-term use of, say, methamphetamine or alcohol, for instance. So it is quite a variable time frame. And I suppose in my feedbacks, depending on the level of impairment that I'm seeing on assessment, I might be cautious about how much recovery saying whether a client might expect a full recovery. Sometimes I'm quite cautious on that front, but I would generally often say that there is always scope for at least some sort of recovery, as well with the added emphasis of providing the right level of supports and making sure there's appropriate services in place for them, and with that might put them in a better place.
Thank you very much. We just did have another question about referrals to other services. I'm just wondering if there's such a weight, what is your recommendation for clinicians or workers to do?
So one of the things that we often, in terms of referrals to other services, is what we can offer for neuropsych is if there's a diagnosis, for instance, of a brain injury, we can make recommendations on referrals to acquired brain injury services and services like our bias, for instance, that require that diagnosis to be confirmed for them to be eligible for their services. As well, we can that opinion can be useful for obtaining disability services for the clients at NDIS or other disability support pension. But as well, we can, as part of that assessment, we're often trying to identify some of the other issues that might need to be addressed. So we often might make a referral for a psychiatry review if we feel that that's more of an important area for them to address, or other trauma or support counselling services as well. So that's sort of the idea with the assessments, is trying to identify some of those key recommendations to signpost them in the right directions. And yeah, I guess with neuropsych referrals to looking at other services, other neuropsych referrals or services generally have quite lengthy wait lists as well. So I guess if you're looking for clients looking for services to refer your clients to, then getting in early is generally the best bet on that front.
We've just got a couple of more slides, and I'd like to thank you both, Kathryn and James, for your presentation. That was really, really useful. We'd just like you to note that this is where you'll find the neuropsychology service. It's now at 110 Church Street in Richmond, the same phone number as previously for Turning Point, and there is also an email address there. We'd like to certainly thank all of those people who have participated, asked questions. Thank you for coming along to our very first webinar. You'll see that you have an opportunity also to complete a quick exit survey. But before you go, we'd like to let you know that there is number 2, the second Connect and Learn webinar coming up, which is titled The Dark Side of the Rainbow. And this is AOD Issues for LGBTIQ, which is presented by Turning Point's Dr. Kerry Alexander. This will be on Wednesday, the 21st of February from 1 till 2. And again, just go back to Eventbrite to register. So I'd like to thank you very much for everybody being involved, and we'll finish off there.